Good afternoon, friends. I'm Dr. Meenu Singh. I'm a professor of pediatrics at Advanced Pediatric Center, PGI Chandigarh, and I'm also in charge of the pediatric pulmonology unit. And from today, we are starting a series of webinars on COVID in children. We all know that COVID has taken the world by storm, and a large number of population has already been hit by this virus. A number of deaths have taken place. Although in India the COVID pandemic is seem to be now coming down, we have a decreased number of mortalities as well as the number of cases have decreased. But recently there has been introduction of the mutant of COVID, which is prevalent now in United Kingdom, and some cases have been reported in India as well. This mutant has a capacity to infect more number of people. And otherwise the prevailing COVID strain actually more or less has been kind to children, and they have not been affected to that extent. The numbers as well as the severity is much less. But there are certain reasons to think that maybe the children can get more affected by this new COVID strain. So we thought that it is quite timely that we review the treatments and the epidemiology of COVID infection in children. So I have with us two of our associates. On my left is Dr. Harnoor Sara. She is Scientist C in ICMR Advanced Center for Child Health. And on my right is Dr. Ketan Kumar, who is a DM fellow. He's doing his DM in pediatric pulmonology in PGI Chandigarh. So first the presentation will be started by Dr. Harnoor Sara. So I'll request Dr. Harnoor to start her presentation.
Thank you, ma'am, for the introduction. As we all know that we are almost 9 months into the pandemic, and these series of webinars are basically to evaluate the COVID-19 infection in children. Being the first webinar, this will be an overview of all the possible topics that will be covered in the future webinars as well. So the topics that will be covered in this webinar will start with introduction, some demographics, transmission, clinical features, therapeutics, and then multi-inflammatory syndrome in children. A novel coronavirus, officially known as severe acute respiratory syndrome coronavirus 2, emerged in Wuhan, Hubei Province, China in December 2019. In humans, several coronaviruses are known to cause respiratory infections ranging from common cold to more severe diseases such as Middle East respiratory syndrome and severe acute respiratory syndrome. The most recently discovered coronavirus causes the coronavirus disease or COVID-19. COVID-19 is a single-stranded enveloped RNA virus belonging to the beta genus of coronavirus family. On March 11, 2020, it was declared a pandemic by WHO. Going by the current demographics, the global situation is yet alarming, that is about 84.5 million cases with about 18 million deaths. Going by the Indian scenario, where the pandemic is supposed to be a little on a simmer, there are 10 million confirmed cases with 15 lakh deaths, and in the past 24 hours, 16,375 new cases have been reported. The situation by WHO, which was given region by region, the Americas and the Europe are still having a tough time battling the pandemic with the cases on an increase, whereas the cases are on a decrease in the Southeast Asia and the Mediterranean, Africa, and the Western Pacific. UK recently reported a new mutant strain, which is known to be 70% more transmissible, and it is known to have 23 mutations, mainly on the S protein, which which is responsible for its attachment to the host cell. Going by the pediatric population, on October 22, 2020, a report was published by the American Academy of Pediatrics where they said that 11% of the patients with COVID-19 are children, and children make up 1% to 3.6% of total reported COVID-19 hospitalizations. Between 0.6% and 6.9% of all pediatric COVID-19 cases resulted in hospitalization. Going by the Indian numbers, 14.2% of all the cases in India are less than 20 years. There had been a lot of discussion that is COVID-19 less severe in children? The numbers suggest similar presentation, but what is the evidence to it? A recent article published gave some review of the reasons why it is less severe in children. There are various protective mechanisms in children, such as stronger innate immune response as compared to adults. Then expression of ACE2 receptor varies with age. I would like to mention that SARS-CoV-2 receptor attaches to the ACE2 receptor in our body to enter the host cell. And more frequent recurrent and concurrent infection, children are more susceptible and there are more infections by human coronaviruses in childhood, which confers them some immune response against these viruses. And there is differences in their oropharyngeal, nasopharyngeal, lung, and or gastrointestinal microbiota, which plays an important role in regulating immunity. Higher levels of melatonin, that is, melatonin has an anti-inflammatory and antioxidative properties through several different mechanisms. It basically increases the proliferation of our immune cells, such as NK cells, T cells, and B cells, as well as some granulocytes and monocytes. Off-target effects of live vaccines like BCG and MMR. In the childhood, children are often administered live vaccines such as BCG and MMR for other infectious diseases, and it is postulated that there may be some off-target immunomodulatory effects of these vaccines that confer some immunity against COVID-19. And then there is a less intensity of exposure of SARS-CoV-2 as compared to adults. Going by the transmission, it has been pretty debated by now of all the transmission mechanisms that is possible, and the most common of these is person-to-person spread. The virus is thought to spread mainly from person to person between people who are in close contact with one another within about 6 feet, through respiratory droplets produced when an infected person coughs or sneezes. These droplets can land in the mouth or noses of other people who are nearby or possibly be inhaled into the lungs. Can someone spread the virus without being sick, which means asymptomatics? People are thought to be most contagious when they are most symptomatic. Some spread might be possible from asymptomatic individuals. There have been reports of this occurring with new coronaviruses, but this is not thought to be the major way the virus spreads. Spread from contact with contaminated surfaces or objects. It may be possible that a person can get COVID-19 by touching a surface or object that has the virus on it and then touching their own mouth, nose, or possibly their eyes. But this is not thought to be the major way the virus spreads. Virus can be viable on the surface for a few hours to days. Experiments used high viral loads, that is CT value of about 20 to 22, and that experiments made that the virus can remain viable for 72 hours on plastic, 48 hours on stainless steel, 4 hours on copper, and about 24 hours on cardboard. There has been no robust evidence as of now available regarding the association of SARS-CoV-2 transmissibility and temperature humidity. Risk of transmission. This has been a recent article published in Lancet which suggested that household contacts are at a greater risk than non-household contacts. Among household contacts, the ones that are at greater risk are those who are sharing bedroom or have spoken to an index case for 30 minutes or longer. Among non-household contacts, exposure to more than one case, spoken to an index case for 30 minutes or longer, or sharing a vehicle. Detection for SARS-CoV-2 in non-respiratory specimen. The first case report that was published in NEGM of the first case reported in United States reported that there was stool shedding of the virus for up to 28 days. So it can be detected in stool for more than 30 days, in blood up to 14 days, in some inoculous secretions in semen. Though fecal-oral route is not significant for transmission, role of transmission through non-respiratory specimens is still uncertain. Incubation period. So how long does it take for the symptoms to develop? The median incubation period for the illness is about 5.1 days, and the onset of symptoms will occur 11.5 days in most of the patients. A patient can transmit more virus during the incubation period as compared when the patient actually has the symptoms. Less than 2.5% infected people exhibit symptoms within 2.2 days of exposure, and viral shedding occurs 2 to 3 days before appearance of symptoms. Infectivity declines significantly after 8 days of the symptom onset. The secondary attack rate of this illness has been reported to be about 12.4%, and greater infectivity is during the incubation period. And the risk of transmission through asymptomatic is very low, that is about 0 to 2.2%. Now, what will be the case definitions? Periodically updated by ICMR and the Government of India. We will term the patient as a suspect case if the acute respiratory illness, that is fever, plus cough or either respiratory distress, and the patient has a history of travel to a residence in a location reporting community transmission in the last 14 days before symptom onset, or history of contact with confirmed or probable COVID-19 case in the last 14 days, or requirement of hospitalization with no alternative diagnosis. A probable case will be a suspect for whom the testing is inconclusive or could not be done. A confirmed case is one that is a person with laboratory confirmation of SARS-CoV-2 infection, irrespective of the clinical signs and symptoms. The most common clinical features that are observed in children are upper respiratory symptoms, that is about 26 to 54%. Cough was reported in about 44 to 54% patients, with fever in 32 to 65% patients. Gastrointestinal symptoms were predominant in children with 15 to 30%, and substantial proportion was asymptomatic. Death rates are up to 0.7%. Risk factors associated with severe disease are neonatal age group, male gender, low respiratory tract disease, and pre-existing medical conditions. Now I would like to request Dr. Ketan to look into the therapies part and further presentation.
Good afternoon, all. I'll be talking in brief about the therapeutic aspects of COVID-19 in children. Before going into the details, what we need to understand is that since COVID-19 is a relatively recent phenomenon, about most of the guidelines, there is no definite evidence. The evidence is still evolving, and most of the guidelines are based on expert recommendations, more so in the pediatric age group, in which these guidelines are actually derived from the adult ones or are an extrapolation of the adult data. So currently what the WHO recommends is that all the health systems should have a COVID-19 care pathway in place. What it entails is that whenever a patient comes in contact with the health system, this could be at the level of the primary health center or the community health center or a tertiary health center or even at the level of a pharmacy, he or she should first be screened for presence of COVID-19 and it should be seen whether he or she becomes a suspect. This doesn't mean that upfront COVID testing needs to be done, only relevant questions need to be asked, and if after getting the answers we feel that the person is a suspect for COVID-19, then he or she goes to the next part of the COVID-19 care pathway. At the same time, if the patient does not become a suspect, then they need not enter the pathway and can continue through the health system as they would have done before the COVID-19 pandemic onset. Now, once they enter the pathway, there should be appropriate institution of infection prevention and control measures. The patient should undergo a triage and a clinical assessment should be done. Priority should be given to COVID-19 testing. At the same time, all the supportive treatment and any other underlying conditions should be treated. Once the report of the COVID-19 testing is available and the patient turns to be negative, they can actually exit the pathway and their other health concerns can be dealt with. On the other hand, if the patient turns to be positive, they enter the next area, which is reserved for COVID-19 positive patients. Now, this could have separate demarcations for somebody who has mild to moderate illness and could be cared for in a community center or even could be quarantined at home. On the other hand, most of these settings will have a separate area for patients with severe to critical illness. So here the patients are supposed to be treated for the COVID-19 illness as well as any other underlying morbidities that they have or the initial health concern that they presented with. And once the treatment is over and the patient is considered to be non-effective for the community, they can now exit the pathway, the period of which can be different, and then continue with the rest of the care. So moving on, if the patient needs to be dealt with in a pathway, we need to understand the classification of disease severity. Now, this has also undergone a recent change. While earlier there were four classifications, now there are only 3. So the earlier mild to moderate diseases have now been classified under non-severe. This would practically mean children who have no evidence of pneumonia or hypoxia, or children who have pneumonia but have non-severe disease in the form of only fast breathing or chest indwelling pneumonia. The next category is those children who have severe pneumonia. They have central cyanosis or a saturation in room air of less than 90%, have severe respiratory distress in the form of grunting or severe chest retractions, or could have general danger signs in the form of lethargy, unconsciousness, inability to feed, or could have convulsions. The next higher category is the patients with critical illness who require life-sustaining therapy. This could be because of presence of ARDS, sepsis, or septic shock. Now, the first step is, as soon as the patient enters the pathway, there should be immediate implementation of appropriate infection prevention and control measures. This would include instructions for patients for maintaining a safe distance, for regularly washing their hands, and for observing droplet precautions while coughing or sneezing. All the standard precautions that are applied for all other patients should be used. Contact and droplet precautions should be applied. At the same time, while performing aerosol generating procedures, for example suctioning or sputum induction, airborne precautions also need to be observed. The next step is lab diagnosis of COVID-19. So the current recommendations say that the upper respiratory tract specimens are the preferred sample and they should be tested by an RT-PCR. There is a role of rapid antigen tests, but they are considered to be less sensitive than RT-PCR, so they are restricted to certain situations and only validated rapid antigen tests can be used. Antibody tests are not recommended for diagnosis of current infection because any elevation of antibody would only indicate past infection and is not a surety of current infection. In case where the clinical suspicion remains and the upper respiratory tract specimens are negative, lower respiratory tract specimens can be obtained. This would be in the form of expectorated sputum, endotracheal aspirate in a patient who is intubated, or even bronchoalveolar lavage in rare cases. At the same time, we need to keep in mind that COVID can coexist with other pathologies. So, if clinically indicated, investigation for other etiologies including viral and bacterial pneumonias, tropical infections, and TB should go on. So coming to chest imaging, there are 3 major modalities which could help in diagnosis. This would be chest X-ray, lung ultrasound, and CT. Chest X-ray definitely has limited sensitivity. The advantage is that there is a low radiation exposure and can be done at point of care. Similarly, lung ultrasound can be done at point of care, but the drawbacks is that it has limited accuracy, it is operator dependent, and the most important drawback is that the operator would be in close contact with the patient and will require strict infection prevention and control measures. There is a lot of literature evolving about chest CT. It is said to have a higher sensitivity, but specificity is lower. Said to be able to detect lung abnormalities even before RT-PCR turns positive, because the findings are said to appear as soon as between 0 to 4 days. The obvious drawback is that there is a higher radiation exposure, which is especially important in case of children. There are certain findings on CT which are said to be typical of COVID-19 pneumonia. This would include bilateral, peripheral, posterior or lower lung zone predominant ground glassing with or without consolidation, visible intralobular lines and reverse halo sign. So in case a patient comes to us with any other complaint but the CT still shows these findings, we should keep a diagnosis of COVID in mind since in the background of the pandemic going on. Then there are findings which are said to be indeterminate, which can be seen in COVID as well as in other pathologies. This would include ground glassing with no particular distribution or only perihilar or upper lobe distribution with or without consolidation. And then there are findings which are atypical of COVID, which are usually not seen with COVID pneumonia. This would include isolated lobar or segmental consolidation without any ground glassing, discrete small nodules, lung cavitation, smooth septal thickening or pleural effusions. So while chest imaging is not said to have an upfront role in diagnosis, it does have some role. It is definitely not recommended for diagnosis of asymptomatic contacts. For symptomatic contacts, it can be used when RT-PCR is not available, when the results are expected to be delayed or the clinical suspicion remains despite negative results. For patient with mild symptoms, it can be used to decide on a hospital admission versus discharge. And for patients with moderate to severe symptoms, it might help in deciding between ward versus ICU admission and also to take a informed decision on therapeutic management. For patients who were hospitalized and have their symptoms resolved, it is not recommended to make a decision regarding discharge. Now coming to the management of different disease severity classifications. For non-severe disease, the patients can be isolated at a designated health facility, community facility or even at home. However, this needs to be decided on a case-to-case basis. So for example, a patient who is at high risk for deterioration, for example, somebody is immunosuppressed, somebody who has an underlying malignancy or even patients who have susceptible contacts at home, it would be preferred to isolate them in hospital. Symptomatic treatment is indicated for all, including antipyretics, adequate nutrition and hydration. Especially for children with non-severe pneumonia, we would give antibiotics as per regional guidelines. The parents and attendants need to be explained regarding danger signs so that in case of any deterioration, they can pick it up early and can present to the health facility. Regarding use of pulse oximeters in home settings, there is currently no evidence that supports their use. One important point to keep in mind is that for patients who are at high risk and are going to be hospitalized, it is important to regularly monitor the vitals, and even warning scores such as the pediatric early warning signs can be used. Coming to management of severe disease, admission is definitely warranted at a designated COVID-19 health facility, and it needs the patients need regular monitoring of vitals, use of early warning scores if possible. Oxygen support will often be needed, and the target saturation is 94% during initial resuscitation. Once the patient is stable, the target is 90%. For children less than 5 years, nasal prongs are the preferred modality of oxygen support. And for patients who do not have signs of tissue hypoperfusion, the fluid management should be cautious because excessive fluid can lead to worsening of pneumonia and ARDS. Certain investigations are indicated at admission, including hemogram, biochemistry, chest imaging and ECG, and thereafter they can be done as clinically indicated. Moving on to critical disease, it could be because of ARDS. Now earlier we used, the recommendations used to say that NIV should not be tried in patients with COVID-19 because of risk of aerosol generation. But currently the recommendations say that a trial of high flow nasal oxygen and NIV in the form of CPAP and BiPAP can be given, provided there are no contraindications such as hemodynamic instability, hypercapnia or altered sensorium. However, whenever they are used, all the health personnel in the vicinity and other patients should observe airborne precautions. It should be possible to recognize any non-improvement or deterioration, and initiation of mechanical ventilation should be done as soon as possible. While intubating a patient with ARDS, bag and mask if possible should be avoided for risk of aerosol generation, and rapid sequence intubation is recommended. Lower tidal volumes are recommended, around 3 to 6 ml per kg of predicted body weight in case of poor lung compliance, and in patients with preserved compliance 5 to 8 ml per kg would be appropriate. Proning is something that has definitely shown to be of benefit in adults. The same data is extrapolated to pediatric patients and can be considered, but definitely requires expertise. Other precautions that need to be followed in an intubated patient include use of inline catheters for suctioning, avoidance of disconnection from the circuit as much as possible, and in case disconnection is not avoidable, then the ET tube should be clamped. This is just an algorithm that shows how the oxygen therapy should be started and escalated. So once we start oxygen therapy using a nasal prong or even a face mask oxygen, the patient should be monitored intensively, and if he fails to respond to escalating oxygen, we can go on to NIV, HFNC or BiPAP, provided there is enough experience at the center and there are no contraindications as discussed. If the patient does not respond to these interventions, or if there are urgent indications, that we should immediately proceed to intubation, and invasive mechanical ventilation should be started with lung protective strategies. Septic shock management in COVID pneumonia is similar to those in non-COVID children. Early recognition is important, along with institution of fluid boluses, antibiotics and vasopressor support in the first hour itself, and fluid status should be closely monitored. Now coming to probably the most controversial aspect of therapeutics in COVID, that is the specific drug therapy. Now over the past 1 year, a number of drugs have been put forward as candidates for therapy against COVID. Some of these have been known to have activity against coronaviruses. Some of them are known to have antivirals, and there were other non-antiviral drugs that have been tried. The dust is now settling and there is some data emerging, so we are sure about certain drugs. However, the data still continues to evolve. So first, talking about hydroxychloroquine and chloroquine, currently there is a strong recommendation against use in any disease severity and any duration of symptoms. A number of trials have failed to show any benefit on mortality, duration of ventilation and hospital stay, and also there is no evidence for effect modification by addition of azithromycin. So the WHO says that hydroxychloroquine should not be used. Similarly, there is a strong recommendation against use of lopinavir and ritonavir, which are protease inhibitors. They should not be used in patients with any disease severity and any duration of symptoms, and do not show any benefit on outcomes. However, we should keep in mind that the trials on which these recommendations are based, none of these enrolled pediatric patients. However, there is no reason to suspect that in pediatric patients the outcomes will be any different. So these recommendations have currently been expanded to include pediatric patients also. Next is remdesivir, which is an adenosine analog and is said to inhibit viral RNA synthesis and is actually used very commonly, currently being used very commonly against COVID. Now the WHO gives a conditional recommendation against remdesivir, which means that based on the available data, it is assumed that most of the clinician and patients will choose not to use the drug, keeping in mind the side effects and the advantages. The trials have failed to show any evidence for improved outcomes. In case it is being used, the contraindications remain liver and renal dysfunction. One other disadvantage is that it is available only as an intravenous preparation. Again, none of the trials on which these recommendations are based enrolled pediatric patients. Coming to systemic corticosteroids, these are probably the only drugs for which trials have shown a benefit. For critical or severe COVID-19 disease, there is a strong recommendation to use corticosteroids, can be administered both orally or intravenously. Most of the trials have used dexamethasone in doses of 6 mg per day or equivalent for varying durations from 5 to 14 days. The side effects that need to be kept in mind include hyperglycemia and hypernatremia, and of course in patients with diabetes or underlying immunocompromise, they should be used with caution. However, for non-severe COVID-19 disease, there is a conditional recommendation against using steroids because the benefits do not outweigh the risks, and the trials have actually shown an increase in mortality. However, it should be noted that if the patients are already on systemic corticosteroids for some other illness, then these should not be stopped. Some of these trials for corticosteroids have actually enrolled pediatric patients, but they are still underrepresented. Now this is another trial, PLACID trial, that was held in India under ICMR, and it evaluated convalescent plasma versus standard therapy. It only enrolled adults, 464 adults with moderate disease across 39 hospitals in India. It was an open label phase 2 multi-center RCT, and this trial also failed to show any difference in progression to severe disease or all-cause mortality at 28 days. There are other large ongoing trials. This includes the recovery trial. This trial had multiple arms to start with, out of which hydroxychloroquine, the protease inhibitor arm and azithromycin arms are now closed. The low dose dexamethasone is currently being evaluated and is enrolling only children because advantage in adults has already been seen. The other arms include tocilizumab, IVIG, aspirin, colchicine, convalescent plasma, and combination of monoclonal antibodies, casirivimab and imdevimab. Then there is a solidarity trial. Interim results of this trial have been published and have shown no benefit of remdesivir, hydroxychloroquine, lopinavir, and interferon beta. Now coming to the last part, once the patient has been treated with supportive treatment and any of these drugs that he is a candidate for, the duration of therapy has also now been reduced. For patients who are symptomatic to start with, they can be released from the care pathway 10 days after symptom onset, plus they should be symptom free for at least 3 days. Whereas for patients who have been asymptomatic, they can be released 10 days after testing positive. However, we should keep in mind that release from the COVID-19 care pathway is not synonymous with discharge. Some of these patients might need to require care outside the pathway, as they could have pre-existing comorbidities. There could be COVID-related complications in the form of stroke, thrombotic episodes, or even MISC, as it is now coming up in a big way. And some of these patients might also require physical and mental rehabilitation. So this was regarding therapeutics on COVID-19. Next, we'll touch upon MISC in a brief, and I will request Dr. Hanur to take up the slides.
Multi-inflammatory syndrome in children. It has been a lot debated about, and initially COVID-19 was reported to have a milder course in children. But in April 2020, there was a surge in cases in Europe and UK, and NHS had issued a warning regarding the rapid surge in increasing multisystem involvement. Initially, it was thought to be Kawasaki-like illness, and clinical and laboratory features of MISC were similar to those of Kawasaki disease shock syndrome, and toxic shock syndrome. But the disorder has some distinct features and it needs a clearer clinical and pathophysiological definition. MISC might be distinct from Kawasaki disease with the following features. That is, age at onset of more than 7 years, a higher proportion of African or Hispanic children affected, diffuse cardiovascular involvement suggestive of a generalized immune-mediated disease. There is more cardiovascular involvement in Kawasaki disease. Going by the pathogenesis of MISC, it has been a multiple mechanism has been postulated. The widely accepted one has been that after a person has recovered from SARS-CoV-2 infection, there are antibodies against it, and there's an IgG antibody hyperimmune response which leads to the cytokine storm. So basically all the hypotheses go on to one thing that causes MISC, that is the cytokine storm. Antibody or T cell recognition of self antigens, that is the viral mimicry of the host, that results in autoantibodies, and then antibody or T cell recognition of viral antigens expressed on infected cells, formation of immune complexes which activates inflammation, and then viral superantigen sequences which further activate host immune cells. And all these phenomena leads to cytokine storm. Another hypothesis that has been discussed about is a delayed cytokine storm. In SARS-CoV-2 infection, whenever there is a high viral load, there is blockage of interferon 1 and 2, which further leads to a delayed cytokine storm when there is a delayed interferon response. Another hypothesis is the enabler hypothesis, that is, maybe SARS-CoV-2 acts as a co-stimulator or a priming agent of some triggering factor that triggers the cytokine storm. There is not enough evidence to postulate any single mechanism. Going by the case definition, this definition was given by WHO, that is age less than 19 years, fever for more than 3 days, and two of these following, that is rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation signs, hypertension or shock, features of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities, including echo findings or even elevated troponin or NT-proBNP. Evidence of coagulopathy that can be seen by elevated D-dimers, PT, and PTT. Acute gastrointestinal problems such as diarrhea, vomiting, or abdominal pain. Elevated markers of inflammation such as ESR, CRP, or procalcitonin. No other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcal or streptococcal shock syndromes, and evidence of COVID-19, that is either RT-PCR, antigen or serology positive, or likely contact of patients with COVID-19. There has been another definition that is given by CDC, which is pretty much similar but differs in some aspects, such as the age limit for that is 21 years, and there has to be a 4-week before exposure with the COVID-19 illness. And then they have only termed MISC that the illness should be severe, requiring hospitalization. Investigations, it is must for an MISC patient to develop an epidemiological link to COVID-19 that can be established either positive RT-PCR for SARS-CoV-2 in nasopharyngeal lower respiratory tract sample or positive antibody against SARS-CoV-2, that is either IgG or IgM, or positive antigen test for SARS-CoV-2 or recent exposure to a confirmed SARS-CoV-2 case. Majority of patients, that is 50 to 90%, have a positive antibody test. RT-PCR may be negative in 2 on 3 cases, hence it is not mandatory for diagnosis. There is a line of investigations and how to go by the diagnostic algorithm, which will be discussed in further lectures. But recent evidence on treatment recommendation suggests that MISC with shock or life-threatening disease needs steroid of 1 to 2 mg per kg per day plus IVIG plus antimicrobials and simultaneously evaluate for tropical infections. MISC that is not immediately life-threatening, in that case we will first rule out tropical infections and then give steroid as a first line, that is 1 to 2 mg per kg per day, and IVIG alternative or first line as per availability. That's how we conclude this session, but 4 things that we need to about MISC, which all the parents need to be aware of as well, that it appears to be a rare condition in children and it may show up weeks after COVID-19 infection and causes inflammation across multiple organs such as heart, lung, kidneys, brain, skin, eyes, and GI. Produces varying symptoms in children but can include fever, abdominal pain, vomiting, diarrhea, neck pain, rash, bloodshot eyes, and feeling extra tired. That's where we conclude this webinar. Thank you so much.
So, thank you, Dr. Harnoor, and thank you, Dr. Ketan. We'll now be taking up a few questions. There was a comment which was like a question about the secondary attack rate in household contacts of COVID patients, because as high as 49% has been reported in some studies. Dr. Harnoor, would you have anything to say on this?
Yes, there has been a recent review on this which had calculated secondary attack rate in household contacts, which varied from about 4.6 to 49.6, but it was in varied settings in varied countries.
So, there's a question about the flow of hospitalized patients once the patients report to emergency. I'll request Dr. Ketan to take up this question as to what is happening in our institute and how we are taking these patients to the ward.
Yes, ma'am. How the WHO has recommended, we at PGI are doing quite similar to this. So, once a patient presents to the ER, we don't have currently outpatient services, walk-in OPDs. So the patients come to the ER, and there is we could call it a fever clinic where they are screened for any respiratory symptoms. In case that we think that the patient has fever with cough, with or without dyspnea, then the patient goes to a respiratory room. In case there are no respiratory symptoms and no fever, the patient is segregated at that point itself, and they can go to the ER as they would do in pre-COVID times. In case the patient goes to a respiratory room, then there is a health personnel there are in full PPE where they evaluate the patient as much as possible with the PPE in place. They take a history, they do whatever examination is possible. Based on that, the initial differentials, the patient is then shifted to a ward designated for these COVID suspect patients, which is known as the SARI ward. Their priority is sending a respiratory sample for PCR as soon as possible. At the same time, treatment is instituted for whatever pathology we think is there. We usually get reports on the same day and maximum by the next day. If the patient turns negative, he gets shifted out of the SARI area to whichever area we think the patient can be shifted to. Or if the patient turns positive, then he gets shifted to the COVID positive area, which currently in PGI is in a separate building. There the treatment is continued till the time we think that the patient is non-infective, and then he is again shifted out of the COVID area. So currently this is the plan that we are following.
Yes, thank you, Dr. Ketan. There have been some speculation about how common would COVID be in the patients who are getting affected by the mutant COVID strain, like how many children are likely to get affected. So this actually point has been mentioned in the UK studies and some modeling studies done by the UK Institute of Tropical Medicine. It's said that children are more likely to get affected by this, and recently there were some press reports that probably the pediatric wards are getting full. But later on, there was a statement made by the president of Royal College of Pediatrics and Child Health that it is possibly during the times of winters, the pediatric wards are usually filled with respiratory illnesses, so they are not necessarily COVID patients which are getting affected or admitted children with COVID. So far, we don't have any definite evidence that COVID is affecting children more, the new mutant strain. Although it has increased propensity because it does bypass the ACE2 receptors, which are otherwise considered to be necessary for attachment of coronavirus. So only the future will tell. Another question which is there is about the status of vaccination for children, because most of the vaccination so far has been adults. Dr. Ketan, would you have any comment on this?
So, ma'am, I don't think currently there is enough data on the basis of which we can segregate between how the children would behave to vaccines, or if there is going to be any difference in the behavior of children to adults. So, like in the case of drugs, we'll probably have to extrapolate the data from adult trials to children as well.
Actually, this question is being asked now because most of the trials which have been done on vaccines against COVID are in adults. And the trials have included patients only who are older than 18 years. So whatever data is there, it is not applicable to children so far. Although there have been attempts to extrapolate data from adults to children in all other therapies, but I guess some trials would need to be done in children with COVID vaccines to look at the side effects, especially the safety profile and then the efficacy as well. So this question, but very soon there will be trials done on this in this particular field, and some answers can be found. So are there any more? So there are no more questions. With that, we wind up our webinar today. And we will be having another webinar on the 27th of this month, which will be on pulmonary manifestations of COVID-19 in children. Thank you very much. I'd like to thank Dr. Harnoor and